Hi guys, so this is the first video on antibiotics from my side taken from Nelson. We've all been taught about antibiotic stewardship, but nobody actually read or taught us much about antibiotics. So I thought that first let's cover the various spectrum of various antibiotics so that we know what to prescribe when. So let's start. Oral cephalosporins. We all have prescribed cefixime, we all have eaten cefixime. So which group does it belong to? It is a third generation cephalosporin. Now, we rarely see penicillins being prescribed, the reason being that cephalosporins have a much greater spectrum of activity, greater safety, greater palatability, so we prefer them. Penicillins are better. Among cephalosporins, there are various generations, first generation, second generation, third generation, and so on. As we progress in generation of cephalosporins, we see that their activity or their cover changes from a gram positive to a gram negative cover. So first generation cephalosporin is good for covering gram positives, while your third generation is good mainly for gram negative organisms. Also, your cephalosporins till the third generation are not active against MRSA or anti-pseudomonas, and thus you have to use other drugs for covering them. Now coming to parenteral cephalosporins. Your parenteral cephalosporins may, like the first generation cephalosporin, is cefazolin. It has activity mainly against gram positive minus MRSA, so it's mainly used in surgical prophylaxis. The second generation cephalosporin cefuroxime, which is also available as oral as well as IV. So this has additional activity against Haemophilus and E. coli. Cefoxitin among these only, second generations only, has also got activity against your Bacteroides fragilis. So in non-life threatening infections, you can use it in place of metronidazole. Most commonly used antibiotic will be your monocept, that is ceftriaxone. In liver dysfunction, you change it to cefotaxime commonly, and ceftazidime also we keep on using. So its main activity will be against entry-gram negative. There will be no activity against Pseudomonas or MRSA. Also, there is no activity against Enterococci and Listeria. It's a very good drug that has been used cefotaxime as well as ceftriaxone for meningitis. So meningitis के main कारण क्या होते हैं? Either it is strep pneumo, it is Hib, that is Haemophilus influenza B, or Neisseria meningitis, that is meningococcus, or sometimes E. coli meningitis. तो इन सभी के अगेंस्ट इसकी बहुत ही अच्छी एक्टिविटी है. Secondly, because ceftriaxone is mainly excreted via the liver, you don't need much dose adjustment in case of renal dysfunction. Lastly, you give it in OD or BD doses, commonly BD doses, because of its longer half-life. Fourth generation cephalosporin is cefepime. Fifth generation is ceftaroline. Cefepime has additional activity against Pseudomonas, also against Enterobacter and Serratia. Ceftaroline has additional activity against MRSA, but still it has not been approved for use in neonates, though in children several studies have proven that it can be used. Coming to anti-pseudomonal beta-lactams, they include your piptaz, your meropenem, as well as your fourth and fifth generation cephalosporins. So here, what is piptaz? The tazobactam piptaz is a beta-lactamase inhibitor, just like clavulanic acid is in amoxiclav. So here the beta-lactamase inhibitor binds irreversibly and neutralizes the beta-lactamase enzyme which the organism is producing to develop resistance against the antibiotic. This allows the second beta-lactam drug to act as active antibiotic effectively. So this combination of with beta-lactamase helps to increase the spectrum to say gram-negative bacilli like E. coli, Klebsiella, Enterobacter, Staph aureus, and Bacteroides fragilis. So for Pseudomonas, we are using piptaz and we are using meropenem. But Pseudomonas is a very bad organism. What it does, it easily develops resistance following exposure to any beta-lactam because of its inducible chromosomal beta-lactamases, upregulated efflux pumps, and changes in permeability of cell wall. This is much commonly seen with piperacillin. So piptaz is never used alone. You always combine some antibiotic like amikacin with it. It is not that much seen with meropenem, so it can still be used as a monotherapy for Pseudomonas. Coming to aminopenicillins, so these are essentially the only penicillins that you are using now, besides your benzethine penicillins or penicillin V's. So aminopenicillins will be amoxicillin and amoxicillin clavulanic acid, which are oral formulations. Ampicillin, which is oral and IV, and ampicillin sulbectam, which is IV. So amoxiclav essentially comes in the ratios of 4:1 originally. But the problem is that as more and more resistance developed against pneumococci, you needed more dose of amoxicillin. But if you increase the dose of clavulanic acid along with it, you saw more cases of diarrhea happening. So we made newer formulations with 7:1. And even now formulation with 14:1 amoxicillin is to clavulanic acid is now available. So 7:1 formulation should be preferred and a higher dose should now be prescribed to fight against URTIs. So for ear or sinus infections, the dose is 45 mg per kg per dose BD and not TDS because uh, these have a long T half in the middle ear fluid. On the other hand, for all other places like skin, lung, tissue or joints, you need TDS doses. So that's all. In the next video, we'll be covering the rest of the antibiotics and the spectrum. Hope this video helped you. You can also suggest topics that you want to learn from me so that we can mutually benefit each other. And if you find any mistakes or any suggestions for improvement, they are also welcome.